Welcome back to another episode of Christian Natural Health. Today, I'm very pleased to have Dr. Tony Nalda with us. Dr. Nalda holds a Doctorate of Chiropractic from Life University and built one of the most successful chiropractic clinics in Central Florida. His expertise has made him a highly sought-after scoliosis specialist in both the U.S. and abroad. Dr. Nalda is a Clear Institute's chairman of the board. This is the only nonprofit chiropractic educational and certification center devoted to non-surgical scoliosis treatment and research. He's also a MaxLiving board member and instructor, and a keynote speaker who teaches chiropractors across the world. He's written several books, including Scoliosis Hope, How New Approaches to Treatment Are Transforming Lives, and he has successfully led his family practice for 20 plus years and continues to seek out the latest and most effective modalities for treating patients naturally. Welcome, Dr. Nalda. Thanks so much for joining us.
I'm glad to be here. It's really a pleasure.
Yeah, absolutely. So you have a really interesting backstory of how you got into medicine and also specifically chiropractic. Tell us that before we get into scoliosis specifically.
Yeah, it's kind of reliving that is always not the best experience, but it's
Yeah, I
the
guess.
truth. Yeah, it's the truth. Unfortunately, I was not a healthy child. I started developing really debilitating migraines at a very young age, around 10 years old, and they became to the point where I was almost non-functional as a child. And my parents sought out all the professionals down in Miami. I mean, I had no lack of resources and tried to search for the problem. And the only thing that happened was layering more medications on top of medications on top of medications
Sure.
until I was completely drugged out of my mind. And it was not until a very weird scenario that my mom was in a pharmacy buying me my migraine medication. And somebody happened to say to her, I had migraines and I went to a chiropractor and I don't got them anymore. And my mom had no idea why to take me to a chiropractor. I didn't have a spine problem. I didn't have back pain. I had
Sure.
migraines, but she did. So she'd take me to a chiropractor, and that's what changed my life. I started getting chiropractic care. I started getting my spine corrected. Migraines started resolving themselves. And then I realized, hey, there's something to this chiropractic. And it made me want to become a chiropractor.
Yeah.
I knew I wanted to go into healthcare.
Yeah.
I just did not know it was going to be chiropractic because I was actually gearing more towards traditional medical care and traditional type of, like neurology or something along those lines.
Right.
But I ended up becoming a chiropractor because of my personal experience.
Has it worked? Yeah,
Yeah.
absolutely. Great. So, and then how did you end up becoming a specialist in scoliosis? How did that happen?
Yeah, so that's a great question too, because I graduated chiropractic college and I started practicing in Central Florida, and I really built a relatively large family practice really early in my career, and I was seeing lots of patients, but then I was seeing patients also with scoliosis,
Mhm.
and I had this intrinsic desire to try to improve the shape of patients' spine,
Mhm.
not only to improve the function, but to improve what we see structurally.
Mhm.
And we get patients with scoliosis, and I was doing what I was taught to do in terms of general patient population, and
Mhm.
I wasn't getting the results that I should, or I felt I should. And
Right.
I had one girl in particular that she was a competitive horseback rider, and we wanted really to try to preserve her scoliosis, and it was worsening, and we didn't. And I started searching,
Mhm.
and that girl like sparked me becoming like, there's got to be a way to deal with scoliosis more naturally, because she was looking at this invasive spinal fusion, though, which is not only going to end her career, but potentially alter her entire life. So
Yeah.
therefore, I was I mean, I literally traveled with her. I took her with me to places, trying to figure out, okay, how are we going to figure this? How are we going to get this better? And thankfully we did. And then that kind of sparked this idea of like, there's got to be a better answer.
Yeah. Yeah.
And now, funny, my wife now has scoliosis. One of her
Oh.
daughters developed scoliosis. We treated it earlier. We reduced it. She never progressed. And she was like a high risk case that she should have progressed into a more severe number. So
Mhm.
now it's personal. And like now it's part of my life and my family, obviously.
Sure.
But of course, it's been part of my life for 26 years in my practice.
Yeah, yeah, definitely makes sense. So, okay, so can you, anybody who might be listening and isn't aware of what scoliosis is, give us a real brief overview. What is it? And then what are some of the ways that it can manifest if not treated from a symptom standpoint?
Yeah, so it's funny. Scoliosis has like two lives. It has the adolescent form and then it has the adult form. And basically, what scoliosis is, it's a curvature of the spine, meaning a bend looking from the front. and it has to have an associated rotation or twist associated with it. And to be technical, the angle of degree needs to be 10 degrees or greater on the measurement of the Cobb angle, which is the way they measure the scoliosis on an X-ray. So 10 degrees or greater with associated rotation. The symptoms are very different depending upon what happens. And this is the weirdest part, like, because it's not related to the magnitude of the curve. Like you would think that the more severe the curve, the more symptoms somebody would have, meaning pain or discomfort.
Yeah.
But the truth is, it's not that, because the majority of cases, the curve is developing while somebody is growing. And we never, not say never, in the majority of cases, we don't know what's causing it. It's a multifactorial causation. It's kind of like finding out the cause of inflammation. Right.
Yeah.
There's so many factors that cause
Sure.
inflammation. Inflammation is just, so saying somebody has scoliosis, it's like there's so many variables that we think to be involved in development of the scoliosis. We consider it a multifactorial problem.
Okay.
But when it initiates, it progresses during growth. And of course, we know kids, while they're growing, are very adaptive, and they grow around the curves and they feel no symptoms, no pain, no nothing. Very small amount of kids with scoliosis feel pain. So the only way the curve gets diagnosed, if it becomes big enough to be seen. It's a postural evaluation. It is like uneven shoulders, uneven hips. So in children, the only symptom they have is asymmetry, some type of asymmetry. And a lot of times it gets blown off. Like it's not like that big of a deal because it's not causing dysfunction, it's not causing limitations. So a lot of patients don't get diagnosed. We think we only find about 30% in children because they become big enough to be treated because they can really see the differences, right? But in the adult form, the progression becomes a whole other animal, meaning now as they're growing and they stop growing, the body can no longer adapt. And now they have these curves in their spine, no matter what the size. And now gravity takes over, and gravity starts pushing down on these curvatures in an asymmetrical manner. And it causes very slow progression in the adult form. But the slow progression is now compressive, and it's now compressing asymmetrically, which now can lead to pain and dysfunction. So the number one symptom in the adult form is pain. That's what brings on treatment. The number one symptom in the adolescent form is only asymmetrical posture. So it's two different things.
Got it.
And it can almost be weird for a patient that knows they have scoliosis, because they say, hey, I had a big scoliosis as a child and I had no pain, and now I have it in the adult. So they almost discount their scoliosis as the cause.
Yeah. Okay. That makes sense.
Yeah. And because they don't realize that it's progressing for two different reasons.
Sure.
So the way I like to explain it is that the likelihood of it developing pain in the adult is not relative to size, it's relative to how much you worsen. So you can have a 100-degree curve as a child, zero pain. Biggest curve I've seen in an adolescent, 155 degrees.
Wow.
Yes, no pain. Walked in my office. Because the body has this amazing ability to compensate, especially during growth, right? So we know that it's reacting and adapting and growing around everything, and so walks in my office like any other kid, like going to high school, like it's this crazy 150-degree curve, right? So you're looking almost like a U-turn in somebody's spine, where somebody could have a 25-degree curve in the adult form and be in excruciating pain because of their scoliosis.
Right.
So it's relative to what happens in the adult form. The acquired progression in the adult is the most likely thing. Now, what's the most common pain they're going to feel? By far, low back pain, going down into the left side of the body, left low back pain, left leg, left numbness, left sciatica, because left lumbar curves are by far the most common. So the most classic pattern is a left lumbar, right thoracic, and that's because the body innately moves the spine away from the cardiovascular system and moves and that's just the innate reaction. So 95% curves are that pattern.
Okay. So, and if you catch it in a child, what would you do to prevent the adult manifestation, and versus if somebody comes in as an adult and they didn't catch it in childhood or as a teenager? What does treatment look like from your perspective, and also conventionally? What's there? Yeah.
So let's talk about conventional. Excuse me.
Okay.
Let's talk about conventional first, because conventional is where, this is, I think, the most important factors that we have to look at, because the management of scoliosis in both sides, in adolescent and adult form, is, and to me, horrific. Like it's like the worst management model in the world. And when it comes to treating a problem, it is literally almost no treatment until the curve becomes big enough to consider surgery. There's very little options, and it's because they don't consider the scoliosis to be an issue until they can do something about it to reduce it.
Got
And the
it.
only thing they can do something about it is to reduce it is invasive spinal fusion and surgeries, which fuse multiple, I mean, you're looking 13, 12, 13, 14 vertebrae in the spine. So it's immobilizing the spine.
Oh my
And
God.
they know this surgery is a very high risk surgery. Nobody's just going to discount that. So they have to wait
Until
for
it justifies. Oh,
correct. We justify the surgery. So because of this, no treatment's offered in the majority of cases. The only cases that are treated is one very specific group, and that's going to be adolescent cases that are rapidly going through puberty,
mhm,
and they put them in a brace to try to slow down progression. And they're
mhm.
not trying to reduce it, not trying to make it better. They're just trying to slow it down. That's the only case that's treated.
Yeah.
Outside of that, they're only treated for the symptoms. Like they're treated for pain, they'll give them medications, they'll give them injections, but the curve itself isn't treated and it's still progressing and still causing problems. So
Mhm.
it's a really, really poor treatment model. And in
Yeah.
fact, in the adult form, the scoliosis is almost discounted. They say, oh yeah, you have scoliosis. Don't worry about it. Don't worry about it until it
Until
becomes
it's bad enough.
yeah,
Yeah,
until it
yeah,
becomes bad enough, causing more debilitating pain, more debilitating problems.
right.
And then when that happens, they'll say, oh yeah, you have scoliosis, that's your problem. But now things are so bad, and normally you're in an older stage bracket of life, and we can't do the surgery now anyway because you're not going to survive it. So
Mm,
it's this really bizarre treatment model, and patients come in very frustrated.
yeah.
I see two groups. I see kids and I see older adults, and I very rarely see the middle group, because
Mhm.
that middle group kind of does okay because the
Yeah.
curve is progressing so slow. They're not feeling the effects yet, not too much. They're normally having like what I call like almost everyday or what common back stiffness and pain and
Sure.
fatigue issues, but not like debilitating or life stopping. Like they can still function every day. Somewhere post 40 to 50 is where things start to change
Right.
because
That
this has been slowly growing and developing over their life.
So for an adult who has back pain and they get imaging done and they see that there's maybe some
Yeah.
scoliosis, but then there's possibly other incidental findings, possibly other causes, like maybe they've got a herniated disc here or there, maybe they've got
Yeah.
like a little bit of osteoarthritis or, that do people usually say, oh, it's something else other than the scoliosis? Or, I mean, how
Yeah,
often?
so that's exactly what happens. The
Right.
orthopedic doctors will chase the other findings and not the scoliosis, and the scoliosis is causing all the other findings,
Got
right?
it. Okay.
Yeah, there's no way you can have a scoliosis and not have bulging and herniating discs. There's no way you can have scoliosis and have asymmetrical degeneration and osteoarthritis. There's no way those things can't exist, because if you have an asymmetrical spine, it's just physics, right?
Of course.
The car is out of alignment, it's going to degenerate abnormally. Things are going to wear out asymmetrically. You're going to have problems. The same thing is true with your spine.
Right.
Uh, and so therefore it gets neglected. They don't even, a lot of times I have patients come in and they'll show me imaging and they had scoliosis,
Right.
10 years ago, and they didn't even talk to them about it because they couldn't treat it. It wasn't big enough to put a rod in their spine. So they just, send them out for injections or give them some over-the-counter medications or some prescription medications or some of those
Sure. Oh my
lines.
goodness. So, okay. So if you have a child coming in, no symptoms, but you see something progressing,
Yeah.
what would you do for them to prevent? And then same question for the adult.
Yeah, yeah. So what's interesting is these days the treatment model is very similar,
Okay.
meaning we use the same approaches,
Yeah.
even though they're in different intensities, and then I'll explain. Right. So for the goal of all treatment should be to first stop progression, but the best way to stop progression is to try to reduce the size of curve,
Mhm.
because the number one factor that dictates how fast your curve is progressing or how likely it is to progress is the size of curve.
Sure.
So the only thing we can try to influence is the size. So if we can try to make some curves smaller, especially in the midst of development, we really mitigate risk of progression. And they're going to go into the adult form with a smaller curve, which is very beneficial.
Sure.
So the adolescent cases, we're working very aggressively to reduce curves as quickly as we can, in a younger stage of life. I would
Right.
say 18 years, 20 years or less.
Mhm.
Even young adults can change really well because their spines are relatively flexible. But if
Mhm.
we can get them while they're growing and reduce the curve during growth, it's by far the best, because now they adapt around a straighter spine and
Yeah.
we get the best results, right? So normally we're condensing treatments into a more closer program, or we're trying to think of it like orthodontistry as opposed to therapy. It's
Sure.
like reduction, stabilizing, holding, reducing, and we're layering reduction and reduction and reduction over time to get it as straight as we can get it. Okay, now we hit plateaus. We always expect to hit a plateau because, like I said, we don't know what's causing this in the majority of cases. And normally we're catching it in a point where scoliosis is structural. And this
Mhm.
is what makes scoliosis different than an injury. It is structural.
Mhm.
So it is inherently growing or developing like this. So it's structurally embedded in the spine. So we
Mhm.
reduce it, reduce it, reduce it, reduce it, and then we wean them off, and then we manage them in the adult form. Now, in the adult cases, we do the same thing. We want to reduce it, but
Yeah.
normally it's not as aggressive. We're not layering treatments as quickly close together. We're
Mhm.
seeing them more spaced out a little bit further apart, which I'll explain that in a second. And the goal is still to reduce it, but normally a lesser percentage. So
Right.
with an adolescent, we can reduce curves 30, 35%.
Dramatically. Yeah.
Yeah. Where in an adult case, we're looking, 20%, 15%, depending on the adult. But this is like a later stage adult. The
Mhm.
group in the middle, the 20 to 45-year-olds,
Yeah.
they're like a whole group that could have potentially amazing changes because they're still relatively young and their spine is
Right.
still relatively flexible.
Yeah.
But normally they're not motivated because they're not feeling a lot of problems.
Yeah, unfortunately.
Yeah.
So it's not for the younger kids, is it braces or is it like the same way or is
Yeah,
it
yeah, yeah.
sizes? It's braces too. Okay.
Yeah, I'll tell you. Yeah, we use both things in both groups.
Okay.
We use three types of treatments, and I'll explain what they are. We use something
Yeah.
called intensive rehabilitation.
Mhm.
Now, where most scoliosis patients fail with the treatments that they receive is they're treated like they're injured. So, adult patient, they have back pain, they'll go into a chiropractor, massage therapist, physical therapist, and they say, okay, you have back pain. We're going to go through injury rehabilitation, which
Mhm.
is low dose, long duration. They do a little bit of care over a very long time to
Yeah.
help somebody heal from the injury they received. And it makes perfect sense. That's what I was trained to do.
Mhm.
And that what doesn't work for scoliosis because scoliosis itself is not an injury.
Right.
Yeah. It's a
Mhm.
developmental problem that somebody's grown and developed with over their whole life. So
Sure.
treating it long and slow produces very little structural change, but
Mhm.
it can help them symptomatically. Okay,
Mhm.
so I'm not discounting the symptomatic improvement, but
Sure.
it's not going to structurally reduce the curve.
Okay.
So the founder of Clear Institute, Dr. Wogan out of Minnesota, he came up with this concept is that maybe if we just worked at it really hard in a shorter dose in a shorter time and increase the intensity but decrease the duration, could
Okay.
we reduce this curve in a more aggressive manner? Because what we're fighting is the curve always wants to go back. Like it's this bounce back effect. It's this rebound effect.
Right.
The plasticity that exists naturally in somebody's body. So what he came up with, what if we saw them every day? And instead of only seeing them like one session, we did 4, 5, 6 sessions per day. And we
Oh, wow.
had a patient go through like 4 to 6 hours of care
Uh-huh.
daily for a period of 5, 10, or 15 days and try to reduce this curve so it can't bounce back. And
Right.
this the literally the culmination of this thing called intensive care. And now
Yeah.
intensive care is not like intensive care in a hospital.
Yeah.
It's just condensed therapy in a
Sure.
very short duration to get this rapid reduction.
Mhm.
And the amazing thing is it's amazing how well it can reduce the scoliosis
Mhm.
because the spine has the ability to change shape. It
Mhm.
just always wants to bounce back if there's long breaks between therapies.
Sure.
So
Okay.
this intensive model is the key because we
Yeah.
reduce it quickly.
Right.
However, if nothing happens after this intensive model, the curve will go
And
right
it's
back
still
to
gonna
where
go
it was.
back. Yeah.
Yeah. So now we have to hold this new position, and now we hold it with using home therapy and home exercises that are designed for scoliosis.
Right.
They're called SSEs, scoliosis specific exercises,
Okay.
not general exercises, not like abs and
Yeah.
biceps.
Yeah.
Yeah, that stuff doesn't, and not that I'm against it, it doesn't really manage the curve. So it's something designed based upon your curve type. Okay. So we give scoliosis specific exercises and then we use bracing. And braces that we use are something called corrective bracing. Now,
Mhm.
the difference between the braces that we designed and what I mentioned the orthopedic doctor would use to try to stop growth is they designed something called a Boston brace. And a Boston brace is a squeezing style brace to try to slow progression. So it's squeezing the body, trying to acting like a cast and trying to hold it in place. Where
Mhm.
we built something called a corrective brace, and a corrective brace doesn't squeeze, it pushes. And
Okay.
by pushing, you're trying to push the spine straighter into a more corrected position, not
Okay.
squeezing and just hoping it doesn't worsen. Think of
Got it.
like, yeah, think of like a retainer for your teeth versus corrective braces of your teeth.
Okay.
Nobody would braces on their teeth if the best thing the brace would do was slow down how
How
crooked.
fast they would.
Yeah,
Yeah.
yeah,
Yeah.
yeah. People wear
Sure.
braces on their teeth to make their teeth straighter. So we use the
Sure.
same principles.
Got it.
Same.
Okay.
So we're
So,
pushing.
and I'm envisioning that if you are doing that level of intensive treatment, there's going
Mhm.
to be a lot of muscles that are angry during that period of time, right? I mean,
Well, interesting enough, you would think that it would be like, okay, patients are going to get a lot of pain or sore. Well, no, it's
they're
actually not.
fine.
No, it's not. Most patients have relief because the number one reason they're feeling pain is something called stiffness. So
Okay.
scoliosis has an inherent stiffness. What I mean by that is when you have a patient with no scoliosis and they bend left and right, they have symmetrical
Sure.
bending, pretty
Yeah.
close. We
Uh-huh.
have a patient with a scoliosis, they have a curve built in, and then when they bend, that curve doesn't come out.
Okay.
That's the structural component. They can't bend the other way. When
Okay.
we do our therapy, we're actually trying to push the curve into that opposite position, and it
Uh-huh.
creates a tremendous amount of relief because what ends up happening, these joints become stiff, they
Uh-huh.
hold all their toxins and all their things in them, and they can't get them out because there's not enough motion. So when we induce that motion, they
Mhm.
feel better. They may get like soreness, like exercise soreness, but
That's
not like bad. Like they know it's
right.
inherently
It's a
good
good thing.
because
Yeah.
yeah, because they can feel like they're moving better and being more flexible and those kinds of things.
Sure.
So that's what the intensive care does. It really opens up the flexibility component. That
Right.
way they can exercise their spine better using the scoliosis exercises. And then we can use the bracing to help push and hold everything. And
Right.
then it's exactly like orthodontistry. Every 3 months, we evaluate, we see what we have, and do we make modifications to try to reduce it again, or do we keep holding? With
Got it.
adolescents, we're more likely to make modifications to make future reductions.
Yeah.
With adults, we're more like, okay, maybe we're just stabilizing right now.
Sure.
So that's the main difference.
Okay. So, and as far as achieving results, it sounds like it probably varies depending on level of curvature and age and all of that. But on
Yeah.
average, how long does it take for people to feel? It sounds like they feel relief pretty quickly in that
Yeah,
initial
so
period.
that's the craziest part. Like
Yeah.
we normally know whether this thing is going to be successful within 90 days, right?
Okay.
We're seeing a change within the initial intensive program, but an initial change doesn't mean it's going to stay. So I
Mm,
always say, what really matters is the 90-day evaluation, and then
mm,
in 90 days we evaluate them. And if we're seeing some improvement at that point and things are holding, it's a very high chance we're going to be successful. Very high chance. Now, unfortunately, not everybody is, but I would say that if we accept somebody as a patient, I mean, we can qualify them, we take the right, we have a very high success rate if we accept you, right?
yeah.
Got it? Because
Yeah.
we weed out the ones that we think
Know
that,
what yeah.
yeah, we know we're not going to make it go through something if we think it's not going to work.
Sure.
Okay.
Yeah.
But very high success rate with getting there. So if we get a hold at 90 days,
Right.
then as long as patients are compliant and they're doing what we ask them to do, and we'll be weaning
Right.
them down really slowly and keep an eye on things, we're
Yeah.
going to get a good result.
Right. Yeah. And so you see people from all over, not just in Florida. So people will come in for this intensive session and then go home and monitor remotely. How does that work?
Yeah, exactly like that. We normally send them back to their local doctor, typically a chiropractor, physiotherapist, along those lines, and
Right.
we co-manage them for those 90 days. 90 days we request X-rays. They'll email me X-rays, email me posture photos. We talk
Sure.
on the phone. We
Yeah.
figure out okay what happened, and then we give virtual recommendations. So a lot of patients will travel in for 1-2 weeks. We take care of them initially, send them back to their local doctor because the thing with scoliosis is a lot of patients get treated by doctors and they have scoliosis. But very few doctors will treat their scoliosis.
Right.
They'll treat
Exactly.
the symptoms of their
Yeah.
scoliosis.
Right.
And that's a completely different thing.
Sure.
Right. So we're totally okay. And I'm totally a proponent of patients continuing to seek out that treatment for the symptoms of their scoliosis. We
Mhm.
just help manage their scoliosis in
Totally.
the process
Well,
of it.
yeah.
Yeah.
Awesome. So that intensive period, it's just 1 to 2 weeks typically?
Yeah, it depends on the size of curve. It
Okay.
could be like a 5-day treatment, it could be a 10-day treatment, and then normally with the most severe cases, 15 days.
Got
It
it.
never goes beyond 15. I
Mhm.
tried.
Yeah.
Right,
Okay.
right? Because well, hey, more is better, right? So does this go
Sure.
longer? There comes a diminishing return. The body can only accept
So
so
many
much
at once.
change in one time.
Got it.
It's kind of like imagine getting braces on your teeth too tight day one.
Got it. Yeah. And that'd be
It
awful.
just won't take
Yeah.
it. It won't take it. That's
Sure.
why, yeah. So that's why orthodontists, they layer it over a period of 18 months. And
Right.
that's exactly what our corrective phase tends to be,
Yeah.
somewhere that 12 to 18-month range.
Sure.
And then right around there, we're plateauing, and then we're weaning people out, and we're just monitoring.
Mhm.
That's really the treatment model.
So just curious, I know you've already alluded to the fact that there's lots of different possible causative factors for scoliosis. And so,
Yep.
I mean, I've heard, because you're using the analogy of orthodontics, I've heard people suggest anyway, that part of the reason why teeth end up becoming out of balance, where historically possibly that wasn't happening nearly as much, has to do with, smaller mouths and sinuses getting smaller and things like that. Can you speculate on some of the reasons why scoliosis occurs? Like I know you
Yeah.
said there's a lot of ideas, but just
Yeah,
curious.
yeah. There's many theories, but I would break these theories down into three
Okay.
main, right?
Okay.
So something called a neuromuscular problem, some
Okay.
type of neuromuscular issue. Now, neuromuscular issues are like autism, right? There's a huge spectrum,
Okay.
and some people know they have a neuromuscular disease, and it's very obvious they have multifactorial system problems. But some people have neuromuscular findings and not be diagnosed because it's not big enough to diagnose.
Okay.
Okay, so what's something that affects the nerve system, something that affects the ligament system, something that affects the muscle system. So either laxity or rigidity in the neuro and like I saw you had a blog about Ehlers-Danlos syndrome. Like Ehlers-Danlos
So I was
syndrome is
wondering, yeah.
associated, yeah, it's associated with scoliosis because it's laxity. There's a lot of laxity conditions, Marfan syndrome, and then
Yeah.
there's syndromes that create rigidity,
Hmm.
cerebral palsy, neurofibromatosis. So it's some type of underlying neuromuscular condition that may be diagnosable, but
Right.
they could be on the spectrum of this.
Yeah.
Yeah, but they can't diagnose it, right?
Sure.
Something that genetics. We know there's a genetic component. They've done studies on identical twins. They found 60% of identical twins to share scoliosis, but
Yeah.
40% don't, but
Wow.
60% do. So there is a genetic tendency.
Yeah.
I think it's more like an epigenetic approach,
Yeah.
but there is something there because I'll see some families, every person in the family has it, and I'll see some families, one person has it, right?
Mhm.
And then the last one I would say is something environmental,
Mhm.
traumatic exposure, something nutrition wise, malnutrition that affects hormonal development, growth, and along those lines.
Right.
And the problem is all those factors will express them, all those causes will express a curve in the spine.
Got it.
And the curve will be really small, and then it will progress really slow until they go through growth, and then the curve will progress, has a potential to grow with them
Right.
while they grow.
Got it. And possibly if it was something epigenetic or something toxic when they were growing, by the time you see them, if they're adults, it's long gone. It's just now we're dealing with the sequelae, right? Or the
100%. Like I always tell patients, if we knew the cause, it may not affect your treatment. In fact, in
Sure.
the majority of cases, I would think 99%,
Right.
we're going to treat you the same way.
Right.
Because if somebody truly has a diagnosable neuromuscular condition, they have something that we know it's there, say
Yeah.
cerebral palsy, we
Yeah.
still treat the curve like a curve.
Right. Yeah. 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 That
Yeah,
makes sense.
yeah, you don't treat the cerebral palsy and the curve gets better because by the time we treat them, the curve is structural already. It's
Yeah.
developed its own problem. It's becoming
Right.
its own thing.
Sure. Yeah. That makes sense. So what have I not asked you that you want to make sure you leave with our audience?
Yeah, I mean, you can see there's a lot to talk about, right?
Yeah,
I would say
absolutely.
I would say the most important thing is that if you have scoliosis, and especially in the adult form, and you know you have it, the worst advice you can ever be given is not to worry about it, right? Minimally monitor it. Minimally take X-rays every couple of years, see what it's doing. We expect very slow progression, but slow progression is what leads to more rapid progression as you get older.
Sure.
And then if you have it, I would always recommend try to treat it. Try to treat it, reduce it. You don't have to, you're not going to cure it, but you have to manage it because you're not going to get rid of it. So you have to, at some point, the curve is going to progress to a point where it's going to require your attention, right?
Hmm.
We know spinal disability is one of the number one causes disabilities worldwide, right? Right. It is growing. It is not going down. We expect patients over age 60, somewhere around 30 to 50% of patients have scoliosis. So it's a big deal, right? It's a big deal. So I would say manage it, treat it, do something about it, and minimally monitor it. Because if you don't monitor it, and then the first question I ask is, do you have any memory of what your curve was? We
Right.
don't know how much you worsened over time. And
Sure.
it makes it harder to manage.
Right. Yeah, that makes sense. So where can people go to learn more about you and your clinic?
Yeah, so my website, scoliosisreductioncenter.com is, a great resource. There's a lot of videos on there, a lot of blogs. I have lots of information. I have a YouTube channel with hundreds of videos on scoliosis. Again, just Google Scoliosis Reduction Center or YouTube search Scoliosis Reduction Center. And then, of course, I have the nonprofit that I'm a chairman of the board of, which is Clear Institute. And they're based out of Minnesota. And we have a nonprofit that we have, doctors that are kind of learning the process and supporting this process
Mhm.
worldwide. So we have like 30 or 40 doctors that have gone through the certification. And those are your main resources, I think, that will guide you in the right place.
Fabulous. Okay. I will put all of that in the show notes. Thank you, Dr. Nalda. This has been really enlightening. I appreciate it.
Yeah, thank you for having me.